I'm Sarah Russell.
I'm JQ Walker.
I'm Hind, and we are
The Neurodivergent Report, a research-based podcast by and for neurodivergent brains.
In each episode, we'll explore topics relating to neurodiversity and coping strategies by reviewing the literature and discussing current topics.
We will also have interview episodes where we sit down with experts in the field and listeners like you, with the hope that together we can all learn to heal in community.
However you are able to engage, thank you for being here.
Do you guys have
Yeah,
this?
I
Ice cream?
didn't-
It's really good. It's called Rocket.
Oh, yes, we have something. No, oh, wait, no, it's different. We have one where it's like a rocket pop where it's like red, white, and blue because
We
America.
have that too, but this is
Yeah.
way better.
Yeah.
Is it
Is it just the
chocolate?
two flavors?
I
I-
love bomb pops just because I like to be like, yeah, bomb pops.
Yeah. Okay, but now I think we got a lot to cover. So if you guys are cool with
Let's
it,
do
I'm
this.
ready to lock
An
in.
insane
Yeah.
amount. Yeah.
Lock in.
Okay.
Yes.
Amazing. Okay, so this is going to be a fantastic episode
We are all
a
very
batch
excited.
of
Yes.
episodes. I have a super bendy body. I didn't know that was like a problem? Question mark to be determined. So hi, we have the full Neurodivergent Report crew on deck today.
We do.
I'm Sarah. We have everybody else, but
Yes.
our wonderful guest today is Dr. Sam. May I call you that?
I'm not a doctor yet, but I really appreciate it. It's okay.
I really want to call you that just because of have you ever watched The New Girl?
Yes. Oh,
Do you remember when she dates Dr. Sam, the tall one?
Oh,
Anyway, today our guest is Sam Silverman. I don't even know how to begin to introduce you because of the depth of connection that we have. Do you want to introduce her, Jay?
And so not only do we have all the crew today, but we also have a very, very special guest. Not only is she incredibly smart and just doing really, really cool stuff, but I have had the honor of like knowing her since 4th or 5th grade. Like we used to ride the bus together. And it has been just so great to have her be a part of all of this, but I will let her do the introducing of herself. So Sam, tell us who you are. Take it away.
hi. I'm Sam. I am in orthotics and prosthetics, so I currently work in healthcare. I have a BS in biology and master's in orthotics and prosthetics, and I'm currently working on research and in my residency trying to get certified, but I'm also really excited about this topic, and I'm going to pursue a PhD in this specific topic, so I'm really happy to be here.
Slay.
Slay. Actually, slay. Yeah.
All right.
Okay.
Okay.
Now we have to figure out how to transition into stuff, but
Yeah, I feel like we always endeavor, like, we always try to tackle the biggest topics. We're like, what is neurodivergence? Let's
Yeah,
put that in
let's
a
define
single
that.
episode.
yeah.
So, keeping with that fashion, I think, this first episode is really going to focus on what is hypermobile Ehlers-Danlos syndrome, because I only just learned about this like maybe 2 years ago, and it was because of a random girl that I had just kind of met who worked in a hospital, and like it was just when I was starting to have problems, and she was like, "Ooh, girl, EDS though."
Yeah.
And I was like, "Okay," and I looked it up and I was like, "No
Ooh.
way."
yeah.
So
Yeah.
this episode is going to be like, what is hypermobile, but also
well,
what do you envision? Yeah, you're trying to jump in.
so because I think that what you were just saying, Sarah, is kind of the experience of like a lot of people who end up having hypermobile Ehlers-Danlos syndrome.
Yeah.
There's a few different types of Ehlers-Danlos syndrome. Hypermobile just being one of the 13 that there are, but it's a common experience to be kind of like bendy growing up, but then maybe around your late teens, early 20s, all of a sudden having all these issues coming up.
Things that you
So-
normalize for yourself. Yeah.
Right.
The
And things-
joints
You get
that
hit by a truck.
dislocate, the,
Yes, get
the
hit by a
tricks
truck.
that you can do in the classroom.
Exactly. Even like having
Um,
I had crowded teeth. That's part of it as well. And having
Whoa.
those things being maybe even normalized by your family because
Yeah.
they might be
I have
hypermobile. And
that too.
yeah. Anyway,
Yeah.
so
And
coming
No,
having
back-
and I
access
love
to-
this because for me, the moment my moment was right after I had given birth. So my hormones were all in flux. Like I had just finished my postpartum 1 year period, although I think that the hormones sort of take longer to normalize than that, but whatevs. I'm not an
Yeah.
expert. Um but we have sort of, anyway, I'm jumping a little bit ahead,
No,
but
you're good. You're good.
as someone who had just given birth and was in all sorts of pain, had actually slipped a disc, learning about Ehlers-Danlos syndrome, hypermobility in general, and then learning the statistic that the average person with EDS sees 15 and a half clinicians and waits over 10 years for a diagnosis. I was like, oh yeah, sign me up. Like
Yeah.
I mentioned it to a few of my doctors that I already had, and they were like, okay, well, who diagnoses that? And I was like, I don't know, you? Question mark?
Yeah.
Yeah.
I mean, like,
We don't
I've-
even know how to get diagnosed.
because I've even I forgot where I heard this
So-
from, but I remember someone saying that like hypermobile Ehlers-Danlos syndrome, or I think just even Ehlers-Danlos syndrome, is like a sentence in like the textbook that they read when they were like getting their doctorate, and that's why, because I want to transition into like kind of the bulk of what we're talking about, but. And to do that, I want to talk about, so it's underdiagnosed. So to talk about it, it's, good to get awareness out there, but also of the link between neurodivergence and hypermobile Ehlers-Danlos syndrome. So Sam is somebody who knows about that quite well from personal experience and from her
What
work.
do you
and
mean?
That's why, well, that's what we're about to
Wait,
jump
there's
into.
a link?
Yeah.
Yeah.
Sam, tell me more.
Yeah.
Yeah. So hypermobile Ehlers-Danlos syndrome is not just I'm super bendy, I'm super flexible. It really is a systemic problem. And we'll get into it in detail a little bit later, but there are a lot of shared genetic and neural pathways that we see presenting with individuals with hEDS and with neurodivergence. And there's a huge correlation as well. And there's a lot of common comorbidities. So in the hEDS population, we see a lot of, most commonly, anxiety, ADHD, and autism, and vice versa. In those populations, in those neurodivergent groups, we see a lot of hEDS as well.
Amazing. So, okay, so definitely I think our first segment here is going to be the bulk of what is hEDS. So, before we really dive into that, I just want to make sure that I frame this episode for everyone by letting them know that we're going to be quoting lots of peer-reviewed research. Pretty much everything that Sam knows about this topic is from peer-reviewed research, just sort of having finished a degree in this. So also in the show notes is going to be like a full references section, like as if we had just done a paper. So
Okay.
I have a paper
for
with
that.
all the
Like, be
references
excited
listed
for
out,
that.
so I'll just share that with you guys.
Oh, awesome.
Yes. Because actually there are nerds out there who are gonna go looking for these papers.
Yeah,
I know it.
for sure.
I know
I
it.
would.
And we love them. And we love them
Same.
for that.
And we love you for that. Yes.
Yeah. So I guess we'll dive in with like Sam. If you
So
want to tell
yeah,
us about...
I mean, sorry.
No.
I was just gonna say she sort of explained a little bit more about how it's a multi-systemic problem, meaning like it's more than just your skin is loose. So like, and then there's different types of Ehlers-Danlos and like hypermobility in general, and that's sort of a problem. It kind of makes it like really confusing.
Yeah, I mean, I
Anyway.
have a few bullets here that will try to break things down a little bit. I want to introduce it as if someone's never heard of it before, because when we're bombarded with all these symptoms, we suddenly come across this information. It's kind of like we just got hit by a truck of symptoms. We're struggling with our symptom management. And then there's a little light bulb where we find out, oh, EDS is a thing. What's that? And we realize how far reaching and systemic this thing really is. So what is hEDS? So hypermobile Ehlers-Danlos syndrome is one of 13 subtypes of Ehlers-Danlos syndrome. It is the most common. And what EDS is, it's really a connective tissue disorder. There's a genetic link. We have improperly formed collagen type 5, which essentially is the glue, the matrix that holds our bodies together. So connective tissue, also referenced as fascia, it's supporting our bodies. It's connecting things and separating things. And it is essentially the structure, the foundation of everything. And when we have improperly formed collagen, everything's loosey-goosey. We lose that structure. So it's not just I'm hyperextending my elbow and my knees, and it's not just my skin is really flexible and lax. It's way more far-reaching than that, because connective tissue is literally everywhere.
Yeah.
Yeah.
Intestines.
Eye lens,
Well,
right?
yeah.
Your
Yeah.
veins,
Veins.
yeah, everywhere. We
Your
have
ears.
Mhm.
your eyes, everything.
Holy
So
cow.
we have this chronic instability, we have this chronic pain, but we also have all of these other symptoms that people don't even understand when they breach the surface, which is fatigue, gastrointestinal issues, pelvic dysfunction, prolapse, hernias, dysautonomia with your endocrine and exocrine dysfunction. You have
And they
cardiovascular
look-
complications.
The worst part is that this all looks like separate things are
Exactly.
going on with you.
Exactly.
Like the doctors, you'll go to your doctor and be like, I don't know why, like, oh gosh, I suck at coming up with examples.
No,
Like,
it's
this
okay.
literally happened to me, so I don't know.
Yes.
But
I think people understand.
Oh, okay. I went to a neurologist and I was like, my leg is literally numb. And he was like, I think it's your autoimmune thyroid condition. And he sent me on my way. A slipped disc I had, and then several tears in my lower spine. And so yeah, there's not going to be any consequences for him, like
Mhm.
fucking up that bad.
And
There's a lot of dismissal.
what's interesting too is like that's a very similar experience that a lot of people
And
who
I
are trying to
waited
get-
like 6 months in between all of that shenanigans just to find out that I had a slip disc and I needed PT immediately.
yeah.
And I waited so long to get that because of waiting on neurology.
Yeah, which like is
So
a
anyway,
very
that's why it's super important for us to be talking about this right now, to sort of connect all of these symptoms and then tell you, like, yeah, go here. Yeah, tell this person this trigger word and then this series of events are going to occur, right?
yeah. Wait,
Yeah.
and really quick, I just wanted to say too, I was trying to get at it like that this is a very similar experience to like people who are trying to get like an ADHD or autism diagnosis, where they get slapped with all these different like anxiety or social anxiety and depression and BPD, like all these different things, which
Mhm.
some of it can be true because it's a consequence of being late diagnosed, but some of it is just it's just ways of explaining all these symptoms. And yeah, so one thing, Sam, that you mentioned in your list was chronic pain, and I know there's a lot of different kind of like in that realm of chronic pain, a lot of different things that people can experience.
Yeah, that's the main issue is with symptom management, is that our pain is ever changing every day, even throughout the day. Our pain changes location and severity, and there's different ways to manage that pain. There's so much pain that we have. And for most of us, we live in a state of continuous, never-ending pain. Just depends on the severity of that pain and what's going on.
And just
We
management.
can have, with soft tissue injuries, we are constantly dislocating, not only when it happens, but to reset it often. Arthralgia, myalgia, so pain that comes right from our joints or our muscles. Back and abdominal pain are super common. Compression and peripheral neuropathy or nerve pain. So neurologically speaking, we have TMJ or temporomandibular joint dysfunction. A lot of the time our jaw doesn't sit in the right place.
It clicks when
It
you're
clicks
trying to chew,
and your
open your
masseters are
mouth,
constantly
like,
trying to hold things in place, and it just hurts all the time and you're just sore.
You probably have like a
ribs,
hump
rib
on your
pain.
back. Like
yeah.
the physical therapists out there, like, no, they can see you and know, like, ooh, that person is in pain.
Yes. We have headache disorders too from our posture, but
Sorry.
also from neurological implications as well.
Yeah.
Or we commonly see painful menstruation more than the average woman or non-binary folk. And then we are also compensating all the time. You guys probably know this anecdotally and from your research as well, but we don't do things properly. We don't even breathe properly. We're using all of the wrong muscles and systems to do things. And when our ligaments are not holding us up properly, our muscles will compensate for that. And that causes overuse, injuries, and pain all the time.
So, Sam, I have a
Just-
question. So,
Yeah.
let's say I'm a parent and I have a child. What signs should I be looking out for
a
when
good
it
It's
comes
a
question.
pediatric, from a standpoint of pediatric chronic pain in children is never taken seriously. It's always,
Yeah.
oh, this is growing pains and they'll get over it. Toe walking, for example, number one thing I hear from a pediatrician is they'll grow out of it. It'll get better. And it doesn't. Children's concerns are not taken seriously. The pediatrician's always talking to the parent. So as a parent, take what your kid says very seriously. If it's a chronic problem, if they're making the same complaint, log it, write it down. As someone who has a somewhat rare chronic illness, you have to log everything to show them this is what I go through, because the minute you step
Yeah.
into the doctor's office, it's not there anymore. It goes away and you can't prove this anymore. So taking what your kid says very seriously, because they're not going to come to you if they don't really have a problem, logging it, things like that, and looking for hypermobility in children. Children aren't all flexible. So.
Mm-hmm. And additionally, like, I know, and correct me if I'm wrong, that like a lot of the symptoms tend to get a lot worse when you get into like late teens, early 20s, is like a lot of when people notice. Is that
I bet it's
right?
the hormones too. That's
Yeah.
probably
Yes,
why
there
we see
there
it
is a
around
link.
then.
There is a link between puberty and when that truck will hit you. Like, the metaphor of like all of these symptoms being bombarding your body and your mind at the same time, and you don't know where to look or where to start. And hypermobility isn't usually one of those number one considerations at that time, but hormones do have a lot to play. And then menopause as well. You could see another influx of symptoms, and we don't think about that because a lot of the people that we're studying right now with hEDS are young adults.
Yeah. So how does it manifest differently or more severely when the person is in their early 20s? What is maybe, I mean, for sure when you're in your early 20s, you're more capable of articulating your concerns 100%. But
Yes.
what else do you think?
So from a research standpoint, it's hard to say exactly when this is happening, because it does take so long to get your diagnosis that oftentimes you kind of miss that boat. But I don't know if this is just anecdotal or if it's real with the hormones and like you ever heard of a second puberty? When you get into your early adulthood, your hormones kind of adjust and they change a little bit. And it could be similar to what we see in puberty with these individuals who have pretty pronounced symptoms.
Yeah. Well, I've
I lost
also
my
heard an
train of thought.
explanation. I've heard an explanation too of what you were saying before about how you're constantly overcompensating, right? So like in terms of like the muscular, like the muscular issues you might have, it's your body just has been overcompensating for so long, and now you're finally seeing the actual results of that.
The physical burnout.
Right.
Yeah. I think
you're supposed to be in the peak of your life, and then all of a sudden you crash and you're just like, I thought I was invincible. What's going on?
It's interesting because the same kind of route is the ADHD route, which is it gets worse during puberty. And most of the time, from my understanding, is that people's symptoms start getting worse. And it's not that they start getting worse. It's just that your coping mechanisms also, started, you're burning out, basically. So you would say, oh, when I was a kid, I was able to focus so much more. Now I can barely do it. Multiple factors obviously are contributing to this. I think having more access to phones, maybe when you're a kid, you're more likely to be physically active and therefore that reduces the symptoms. But for sure, I think it's the same route. And it's interesting. I like what Jay said, and that, also your body's maybe done overcompensating. It's just too tired.
It's like unmasking almost in a way.
Yes.
Your body is like, hey, this is who I really am. I'm falling apart. Can you take care of me, please?
And so you mentioned that a lot of the people in the study are young people. Now, is that a good thing or a bad thing? I.e., what's the prognosis like for them when they're
right?
Is
so
it younger you are, the better? And what should we expect?
Really does, I think, depend on the resources that you have and how your team, how multidisciplinary is your team. Because when you hyper focus on one issue, you're missing a lot of other stuff. If you only have a physical therapist and a physician on your team, you're kind of lacking, right? So this doesn't necessarily relate to the study, but the outcome, your quality of life per se. You may need a physical therapist, a rheumatologist, a geneticist, a psychologist, all these things.
Sorry.
Yeah, go ahead.
I just wanted to flag that we were going to focus on symptom management and stuff in the next episode.
Oh yeah.
So
Sorry,
I just wanted
I had
to.
a feeling that I jumped to.
No, it's okay.
Stay on top.
Because we're totally talking about like the journey to diagnosis, and that is such a neurodivergent thing too, because it's like it in some ways it just doesn't look like anything. It just looks like you're complaining a lot.
Right. And especially when you have these neurological or you're neurodivergent as well, a lot of the times you 10 times more likely to be hypermobile as a woman. Oh, you're a hysterical woman, or go to the psychiatrist and figure it out. Your body is actually
and then
a symptom
so
of
this
your
gets
anxiety.
misdiagnosed.
All the time. There's a huge dilemma because every physician, every specialist that you see has a different level of understanding of EDS. And it's so funny because I say this all the time. Your 1 hour lecture has nothing compared to my 10 years of experience in my body. So maybe listen to your patients.
And it's interesting that you're saying you're hysterical or you're exaggerating, because women are more likely to get this, this
10
genetic.
times as much, yeah.
I feel compelled to mention every time the concept of hysterical woman is brought up, that was birthed at exactly the same time period as the rational scientific man. So that's misogynistic propaganda.
Well, it is. And hysteria comes from, we say hysterectomy uterus. So it's basically saying,
because you can't fix me.
Hysterectomy literally means take the hysterics away.
Yes.
Yeah. So hysteria, you're being or having a uterus. That's what you're saying to that person. And now that's considered an insult, or that you're unreliable.
Yeah.
So I'm finding it interesting that disorders that are more likely to happen in women usually are underdiagnosed. I think that's...
Can we also stop and say that hysterectomies don't even solve the problem 100% of the time?
What do you mean?
Explain.
I don't know. I mean, I know.
So taking out your uterus doesn't necessarily stop the pain that you experience from hormones. It just like now you no longer have that tissue to attack. So like your body's gonna attack other tissue, and that's the part that they don't tell you.
That seems like an important part to know.
Yeah. Well, informed consent is not a part of women's health as a standard.
That's correct.
Yeah,
because they just don't know.
A perfect example. No, sometimes they do know. Like when I got my IUD put in, that was crazy. Like they were like, "Oh yeah, like you can drive back by yourself, you'll be fine." I was
meds, nothing.
Yeah, I was not able to move. I was like writhing in pain, and I'm like, thank God my mom ended up coming with me. But it's like I don't know, like there's I feel like I've heard so many women have situations like that where it's just
it's the same with color discrimination in healthcare. Yeah. Women are tough; they can stick it out, and they don't need all this information because they're already Google. But no, I would like some pain meds with my IUD insertion and removal. Thank you.
Yeah, or I think it's even with specifically IUDs, I think it could be the kind of thing where it's like, oh, it's not like they're cutting anything open. If they're just putting something in, it's probably not a big deal. But
if men had an IUD put in.
Exactly.
On the IV.
Anyways,
I was going to segue into, so it gets easily underdiagnosed or sometimes misdiagnosed. So what is it most likely to get misdiagnosed for? What do you usually see? Is there a pattern?
Is a pattern. A lot of neurological implications, bipolar anxiety. We also see MS sometimes, randomly enough. And fibromyalgia, pain syndromes as well are often misdiagnosed because if they don't know the cause, they can just say fibromyalgia is basically widespread pain with no specific origin.
It's important to mention also that those are usually diagnosed with like a criteria. Like there's like a subjective like criteria that you fill out. It's not like you do a blood test to find out that you have MS.
Right. It's just like EDS. It's kind of an exclusion diagnosis, and what that means is that we may not know the exact genetic markers for this. There may not be a blood test or a genetics test for this, but we can rule out all other reasonable diagnosis by seeing, let's say, a rheumatologist or a geneticist.
Yeah.
Okay. Jay?
Yeah. the thing I wanted to say is jumping back to like the gender differences again, where it's something that I just kind of, we don't have to put this in this because I mean, maybe it has been studied somewhere and I don't want to say something that isn't like research backed, but just like a story to share, is that, so so the IUD was a mess for a lot of reasons. Awful. After that, I was on progesterone based birth control pills because estrogen driven cancer like runs in my family. So I was like, okay, I can't do that. But then a lot of my symptoms got a lot worse.
Yeah.
And I ended up I think I read this somewhere too. Like, I wish I was trying to actually find like where I was reading this, but like that progesterone can make collagen more unstable. So then
Yeah.
I was like, okay, I'll stop doing this birth control. And I've switched to something else since then. And obviously I'm not magically better, but I was really having a rough time.
You were
And
going downhill and it stabilized somewhat.
yes. And I was talking with my now husband, that's weird to say, my now husband Richard about it. And he said, because he was like, well, if hypermobile Ehlers-Danlos syndrome is more common in women, do you think it could be because they have more progesterone than men?
Yeah.
And there could be, and like that was just an
Yeah.
interesting thing.
Yeah.
So the
yeah.
reason why I brought up my postpartum period is because of the hormones thing, and actually my symptoms started to really get worse like when I was like 5 months pregnant. Basically what happened was my ligaments loosened way faster than they were expecting, and I was pretty much like unable to walk at like 5 months and like barely even carrying much weight, but it was just so much pressure on my pelvic bone, and yeah, there was like nothing they could do about it. They were like, yeah, it's the progesterone, it's caused too much loosening, sorry, we can't stop. My doctor specifically said the only thing we can do is get the baby out.
Wow.
And I was like, bet.
Yeah. Bet.
Yeah. So there's
See
obviously
ya.
a huge correlation between the lack of understanding and trust in the patient that you're trying to evaluate and how they present and who they are, which is really unfortunate. It does happen a lot with neurodivergence as well. We see that correlation too. There are a lot of different ways to try to diagnose hypermobile Ehlers-Danlos syndrome. They're all kind of different. They all relate to different age groups and presentations, and they all have their problems, to say the least. For example, like the Villafranche criteria is really great for peds and young adults. And it does get more specific than just EDS. Like there are 6 different subtypes that you can correlate your symptoms to, but there's things missing, right? And there's also 7 other subtypes that are not included. The Brighton criteria is, I had to give them props. It's pretty holistic. It has a lot to do with different body systems, organ systems that we have and how they're affected. There's a major and minor criteria, and also props for including family history as one of the diagnostic criteria because it is heritable, but it also has its own problems. And the Baton scale, which we're all, I think, more familiar with, which is literally just a test to see how bendy you are.
What you can do, and like,
right?
Yeah.
And Julia, do the thumb one.
Well, I was
crazy.
trying. I don't think people can see it, but the
yeah, I hate that.
So you get graded 1 point
or like the
for
elbows.
each side that you can complete a task and show evidence of your hypermobility. And the only really good thing about this test is it does change the criteria based on your age group. So we know that we naturally become less flexible as we grow, the average population and EDS as well, because our connective tissue starts to try to stiffen up and we lose mobility. So at least there's
Does that have anything to do
accounting
with
for
fascia?
age. Yeah, absolutely, 100%.
Is that why fascia also is tight? I don't really understand that.
We need
It
our
sounds
fascia
fake.
to be released just as much as our muscles. When you go for a massage, you get a deep tissue massage, they're breaking up your fascia as well because it can get, the matrix can get super stiff there as well. And when you have this poor matrix to begin with, when it starts to kind of try to solidify and it doesn't always work the right way, and then your posture gets even worse.
That was going to be my question. Since it's going to stiffen or harden, you would think that maybe the symptoms get better with age, but they don't. They just start.
No, because they harden into the wrong positions.
Yeah, it's
Because
not
we've never sat
anatomically
correctly.
correct.
We've never breathed correctly. We've never walked correctly.
Yeah.
Yeah.
The compensations and the overuse contribute to that and in not a positive way.
So this might be a silly question then. Oh, yeah, no.
No, I was gonna ask Sam if she'd ever heard of EDS causing a high ANA blood marker in someone.
Yes, I have. There is a lot of research trying to figure out a
Hins
specific
over here, like
way to a specific way to diagnose this that isn't just exclusion based, like blood markers, genetic markers, things other than family history, and your symptoms are weaving and turning and changing all the time. So I have seen a lot of research recently or proposed, and they're looking for funding. But as we know, when something's proposed in the healthcare field, it often takes 10 years to come to fruition. So this test
That's
is not going to be
okay.
available for a long time, but at least we figured out what markers to look for. And
So
by
interesting.
introducing this idea of there are comorbidities that are shared and are often inherited at the same time, we can kind of dwindle down what markers to look for as well.
And it increases the pool of people that if there's a greater amount of the population that is affected by this, then theoretically more money is going to be is going to go towards that research. And so a lot of times in the disability space or in the medical space, we want to keep things very separate and very unique, and there's merits to that, but then there's also there's benefits to.
Yeah, because I'm looking at this study here, and it says this is a 2022 study that says that 51% of the neurodivergent group had a hypermobility compared to the general population 20. That's a lot.
Yeah.
They linked it. They say that this hypermobility could be the link between neurodivergence and dysautonomia and pain.
And pain. Yep. I have that study as well, and it's all over my paper. And just those specific researchers are exactly what we're looking at right now. That's what they do for a living. That's what their PhD is in. And that's what I want to be a part of, because it's such a major conclusion to draw, and it will bring the funding and the research, and it will force physicians to acknowledge us. It will force them to have some kind of understanding, because as working in the medical field, you can't just go to school and you're done learning. You're supposed to be a student forever. You're supposed to read these papers. You're supposed to understand when new criteria are brought up. So we're trying to push this into the spotlight a little bit.
I'm glad. Yeah,
Amazing.
because when it comes to vulnerable groups or minorities, these kind of studies don't get funded because it's a small group of people. And unfortunately, getting funding is all about how important it is to get money from this. So I love that there are people advocating, regardless of how significant, the money payback is to whatever company.
We have a whole little thing for the next episode about future research and treatment and the zebra metaphor and everything like that. I love that we jumped into it now.
Well, one thing I was going to ask before, I was going to say this might sound silly, but it's kind of more of a colloquial, where this can show up colloquially in terms of when people talk about being neurodivergent. So one thing that I've heard is the neurodivergent walk and the neurodivergent posture, and wondering then, is it linked to then?
100%.
Yeah.
100%. We see a lot of shared pathways and presentations between being neurodivergent and hypermobile, but it's likely that that person mistakes that for their neurodivergence, or it could be one and the same, right? So we have, there's this theory that I'm supposed to go into later, but the how we're feeling and how we're presenting with our posture, it's it goes back and forth. So the way that we feel is expressed in our posture, and our posture affects how we feel. And there's this
which is why tactile grounding works.
Yes.
Well, not even that, but on top of it, Sam, we did this episode and it's coming out soon with Abby, who was talking about ANS, and how another theory is executive dysfunction doesn't actually exist, but it's that if you have a neurodivergent brain, your autonomic nervous system is on high alert all the time. So that can explain a lot of what we call executive dysfunction, and that you can see that also in the way that in the way that you are, in the way that your body is, how also a lot of neurodivergent people have dilated pupils, like more than a neurotypical person. So that's Sorry, that was just kind of like a light bulb
Theory
thing. Where I was
link.
Yeah,
like,
your nervous system is linked
Yeah.
for sure. And in a way, like when you think about your posture, it's theorized that your posture is a direct channel of your emotional communication.
mm,
And I have Tourette's. So when I have a lot of anxiety, my Tourette's flares up. And
mm,
these two things are absolutely unequivocally linked together. And with your EDS, your posture gets more poor, per se, maybe when you have more anxiety and you have more on your plate, and that's why they're
yeah.
connected.
This is bringing me to like what could be possibly the link between ADS and neurodivergence. And we said collagen is everywhere, so it is in the brain. Do you think that the fact that there's this genetic mutation that leads to probably an abnormal process of brain development could be the reason why there's this
Yes.
association?
In the EDS population, we do see altered function in the amygdala, which is the fear and emotional processing center. So there are a lot of
No, not
theories that
again.
I know, that damn amygdala.
Yeah.
We see a lot of neural pathways that are shared between these two populations, and that's why it makes sense that there's so much overlap here.
Mhm.
And I think
You
maybe
know,
one can make us
ADHD.
understand the other, like pathophysiology wise,
Yeah.
Yeah, I think, okay, wow, that's really
We
interesting.
need more neurologists on this ASAP.
Get them on this. Come
There's a
on.
heritable component. There's gene mutations that for collagen that also impact your brain development.
Yeah.
Hello. There
Yeah.
you go. There's molecular, cellular, and tissue level pathways that are all shared between these
Wow.
neurodivergent groups and EDS. So it really just makes sense that there would be up to and even more than 50% overlap.
Amazing. Okay, so we've been talking about neurodivergence and hypermobile Ehlers-Danlos syndrome, and basically, it's a lot of genetic heritability. There's a lot of shared traits, things like brain fog, things like proprioceptive, like movement difficulties, things like
Understanding where your body is in
clumsiness.
space.
I would
Yeah,
just say
totally.
already
Yeah.
the injury is worse. You're already more prone to
Yeah.
injury, and now you have a proprioceptive issue. So I hate this
Yes.
with chronic illness.
And
It's
a
like,
tendency to be super fast.
yeah, this is the thing. It's like a cycle that feeds on itself. Like
It's
with
a
chronic
Exactly.
lose-lose.
Yeah.
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 But this is interesting.
Yeah, but I love this. I love that there are a lot of links actually, because I think it's validating. It's not like, oh, I'm just a clumsy ditzy person.
No.
It's like, actually, I can't like map the environment quite the same. Like my internal
Exactly.
GPS
It's more than
is
that.
not working.
Yeah, and there's
that's
also
cool.
two different variations of that. We have proprioception, which is understanding where our limbs and torso is in space without visual cue, like that test you do at the doctor where you
Yeah.
touch their finger
Yeah.
and you touch your nose. Try
Yeah.
that with your eyes closed. You will fail. But there's also interoception, which is understanding
yes.
the internal structures, not just your limbs and your head and your back. It's I'm doing an exercise and I don't even know what's being activated and how to isolate the right muscles, and I don't know what's going on with my
I
digestion.
need a mirror.
Or
in
it's
order
like,
to know where my body
would that
is.
be like, I don't know that I'm hungry, or I don't know I have to go to the bathroom until it's
Yes.
like really
Sometimes.
bad.
It's too urgent, and then your dysautonomia is already acting up because you needed that nutrition, or you needed to cool down, or you needed
Yes.
that space to recharge your battery, and it's hard to be introspective and understand where you're at physically and emotionally.
Wait a minute. I feel like we're starting to swirl because wait, I can't ever say that word anyway, but like
Dysautonomia.
autonomic dysfunction happens as a result of managing all of this. Is that what you just said?
Absolutely.
Okay. All right. So we are swirling into the next episode, and I love that
right.
for us. I love that for us. We're literally
So
at
that's
the
interesting
end.
to you. And that's interesting
I've already
to you.
started to recap.
Well, no, I want to say that I want to plug it back because I'm like, well, if that sounds interesting to you, then you just have to make sure to look out for when part 2 comes out.
Yeah, because
totally.
we discussed all the problems now, but I would love to see what we can do to tackle it. Chronic pain only as is debilitating. So imagine all the other symptoms. So I'm excited for even my personal, like my personal life. I'm like, I need to hear what Sam says and I need to write it down. Like what occupational therapist do I need to go to? I'm excited for that. And I hope I hope people
Yeah.
tune in and
And
see.
something that I want to say too is that we covered a lot of ways that hypermobile Ehlers-Danlos syndrome shows up, but we also didn't talk about every single thing. And to get a more comprehensive idea, like we're going to be linking like stuff,
all the resources,
sort
of all of the scales that I can find. If there's like a main hub, I think there's the EDS Global Registry.
EDS Society and
yep.
Registry are great resources. Yeah.
Yes.
Sweet.
Because we mentioned stuff about like the skin. We mentioned like stuff about like your like gastro like GI problems, and like there's heart. Like there are more things to dive into. But there's also more diagnoses like to dive into, which is also what we're going to be doing like in the next episode as well.
There's more ways to support yourself than just receiving this diagnosis.
Yeah.
Because it really is, since it is a multisystemic problem, you need like multisystemic supports. Otherwise, you're going to end up with that like spiraling of symptoms.
You're chasing your tail.
Always trying to catch up. Yeah, exactly.
And it's interesting to see the interplay
awesome.
between ADHD and hEDS, you know, when it comes to the genetic basis of it, as well as, you know, the symptoms, how one can make the other worse. And I know for a fact that, I mean, I can't believe people didn't see it, but I remember fracturing, a bone, and I was so hyper, I even broke the cast. So as an ADHDer, you're more likely to break a bone, and that makes you know, the Ehlers-Danlos syndrome.
You don't have the stability.
Me thinking about everyone who broke a bone in elementary school.
Yeah.
I'm all of them. Yeah. So it's to see the link between, you know, injuries, executive function, hormonal relationship. We already talked about ADHD and hormones, but it's interesting to see that it's also with other disorders that are relating to ADHD.
We're always talking about hormones.
Yes.
They're really important.
So thank you all for listening. Yeah, so just to kind of close out this episode, if you want to learn more about hypermobile Ehlers-Danlos syndrome, symptom management, and comorbidities, keep eyes out for part 2 of this episode with Sam again.
Yeah. And one last thing, if you have ADHD and you have chronic pain, you're more prone to injury, you're breaking a lot of bones, you feel something is wrong, trust your body. There's a huge link between these two disorders.
And autism.
With this
ADHD
episode and the next episode, you have more of a, you know, a map of what to do.
Yeah.
Awesome. Thanks for being here.
Thanks.
Thank you for having me.
Thank you.
Thanks for being here. If you want to connect with the Neurodivergent Report, you can find us at ND Report Pod on Instagram, Threads, TikTok, YouTube, Blue Sky, Substack, etc. If you're looking to support the show, the best thing you can do is subscribe and leave us a 5-star review. Please do that.
And hey, if you want to check out more about us, visit our website at ndreportpod.com. And you can also go there if you want to be a guest contributor on the show.
Until next time, be well, do good.
Bye.